Hi, Amanda.
Morning, you okay?
Morning, Amanda.
Morning.
I told you.
Okay, 1 minute and we'll start promptly on time. I think people will join, won't they, as we start?
It'll be a mad flurry just at 10 o'clock.
It will be. It's that last day in before the Easter break, isn't it? Morning, Sarah.
Good morning, good morning. Hi, everyone.
Okay, right, we're on 10 o'clock then, so I think we will make a start because we've got quite a lot on the agenda for you this morning. So welcome. There will be people that will be joining us as we go in, and we're just admitting them in, and we do apologise. We've tried to set the option for bypassing the lobby on the meeting this morning, and it's not allowing that option, so we do apologise, but hopefully everybody will join us soon and the alerts will stop. So good morning and welcome to the March's quarterly open meeting for NQICAN. We'll just ask you to keep your microphones muted whilst all of our speakers are speaking, if that's okay. But obviously turn your cameras on. We'd love to see you. We are recording, obviously, because we'll put the link up onto the NQICAN YouTube channel, and we'll make that link available on the network and sharing forum and also on the NQICAN web pages. So I think in the interest of time then, Marina, if you wouldn't mind moving to the next slide, we'll have a look at today's agenda. So busy, we've got the next 2 hours together, as you know. You'll notice that the chat function is on, so please do pop some questions in as we're going through, but we'll allow you that opportunity to ask questions after each speaker's slot as well. And as Marina always does, she'll do a fantastic job of pulling together all those Q&As, and we'll get that out and published for you should you want to reference back to it at a later date. So just a gentle reminder at this point, just to keep yourself muted while we're talking, if that's okay. So looking at the agenda, Marina and I are going to give you officers update to begin with. HQIP are joining us to give us their updates. We're going to hear from Susan around the recently published outlier policy for the NACAPOT programme, and Julie Nossiter is joining us from the NatCan, the National Cancer Centre Collaborative, to talk to us about the 10 national cancer audits. So that'll be a really informative session this morning. We've got a little bit more time protected for Q&A at the end should you have any additional questions that we've not managed to address at the end of each speaker slot. So we'll just move on to the next slide then, and as always then we're just sharing our health and wellbeing links really with you all, just to make sure that you perhaps do take that time to access them. They are a really valuable set of information to inform us, regardless of whether we need it now or whether at some point in the future. So also we're scheduling 5 minutes at the end of our meeting that we always recommend, just to pause, rebalance your thoughts and where you're at before you begin your afternoon. So we'll move on then to officers update, I think is the next slide. Fantastic. So we'll move straight on to start speaking with you on what Marina and I have been doing. So before I go any further, I just want to announce that we've been successful in our expressions of interest for the comms leader role for NQICAN, and Amanda Stevens is joining us as of the 1st of April as the comms lead. Brilliant contribution to the NQICAN team. Amanda's on the call today, so she's observing today's meetings, our business meeting as well this afternoon, ready to commence post as of next week. So Amanda works at the Lincolnshire Partnership NHS Foundation Trust as a NICE and clinical audit facilitator. So she's bringing a wealth of experience to inform this role, supporting all of our members. I'm sure you're all going to be hearing from Amanda soon through our various comms routes as she settles into that role. So welcome, Amanda. Move on to the next slide, if that's okay, Marina, then, and we'll just have a look at what we've been doing since we last met. So busy again, as always. Marina and I are always saying that every open meeting when we share this with you. Not going to touch on everything that we've listed in the slide in terms of some of the business as usual items that are here, but we have been holding those planning meetings with HQIP Clinical Audit Awareness Week 24. On behalf of all of our members, we've continued to support the NHS Futures platform, that taking action on national clinical audit. If you're not yet a member on that workspace, do please register. The ask really out to our community is to help us build that content now. That platform provides us all with that direct linkage to those national clinical audit providers and also to each other on how we're actually taking that action on the national clinical audit outputs to make sure that we're improving patient care. I think if you recall those members that were involved, we were given the opportunity to contribute to the user needs research, and we did say we wanted this platform. This is the sort of space that we wanted to all be able to join together, but now we need to build that content, make it active and make sure that we're supporting each other. So do head on over and register. And I'm just going to call upon any of our NQICAN core members that are on the call just to pop that link in the chat if you could, please. We get invited to attend the specification development meetings where national clinical audits are up for commissioning for new topics or recommissioning for those that are existing on our NACPOT programme. I've recently attended the National Audit for Dementia SDM meeting, and thank you to all of those that responded to the call out for feedback from our teams and our frontline teams that participate in this audit. That was valuable feedback. I did speak about it at the meeting, and that's been taken forward with consideration for when they put that tender together for recommissioning. As we get these opportunities that arise, I will obviously put those call out for feedback from you all, because it's important. We sit on those meetings, NQICAN, as the voice of our members, the voice of all of you back in your own organisations, so it's worth contributing. I did attend the Executive Quality Group Clinical Audit Subgroup, the EQG CASG meeting. It was the first meeting that was chaired by Stella Vig, who's now taken over from Vin Dawakar as the National Medical Director for Secondary Care and Quality. And we're obviously looking forward to hearing more from Stella as she sets that future direction. I also had the opportunity with my NQICAN hat on to join a Yorkshire and Humber Health Innovation Network event where they were showcasing all of their work to the NHS team for innovation. So it was quite a privilege really to be in that room and to hear about all the improvement work that was going on. And part of that obviously was where NQICAN and Sarah, our co-opted member, who's the head of the Dorset Innovation Hub, on how we're obviously putting on those extra events and webinars and resources for our members in terms of adopting the medtech. So it was a good event. And just finally to say on this slide really that all of this activity that our NQICAN core members are undertaking is supporting driving that forward plan and our improvement priorities. So if we head to the next slide, you'll be able to see that we're just sharing with you again the improvement priorities for 24-25. The highest priority obviously is driving that clinical audit for improvement, and that's through our forum, our NHS Futures platform, the open meetings, the regional networks, working closely alongside HQIP and NHS England on the national clinical audits, and supporting our members with their local programmes and within our local systems. We're embedding the innovation arm of making things better in health and care through our co-opted work stream that I've just mentioned, I'll touch on again. And we are calling upon our members to help build that suite of resources to support us all to evidence that value and impact of our local programmes, and that's through our second co-opted work stream. Clinical Audit Awareness Week, big priority for us every year, and obviously Clinical Audit Awareness Week 24 I'll touch on shortly with you all. And we're looking to run more of those local events and refreshing that education and training directory for NQICAN. So no surprise, I don't think, here on the improvement priorities for the next 12 months. So if we could just move on then, I just want to use this opportunity today just to highlight NHS Impact again to you. Head on over. These slide packs have been put together obviously as a resource for you from our meetings today. So we always appreciate the slides are quite full, but we like to include all the live links for you so it's easy for you to access resources and signposting that we're giving you through the meeting. NHS Impact, these links for all of these events that are free to access, detailed here on this slide, are on the NHS Impact webpage, links on the slide here. These are really good sessions. The sharing event that they've already held and some of the other sessions have been fantastic. So I really would urge you to share these with your teams and your organisations and try and head along to some of these events, because these are going to help us to embed the NHS Impact within our own organisations and across our systems. So yeah, please do share widely. If we head on to the next slide, Marina, thank you. It's just to highlight here, this is obviously a screenshot taken from the Future NHS workspace, that knowledge and learning hub that I've just mentioned. Please do go on and access it. All of the national clinical audits, they've got a page each. You can start discussions, and the beauty of the Futures web space is that as soon as somebody starts a discussion, adds some new content, asks a question, if you've signed up for those alerts, they hit your inbox, and actually if it is something that you could respond to or something you're interested in and think, oh, actually I've been waiting for that, I want to know about that, you can just few clicks and you're back into that workspace, and we can just be supporting each other a lot more with really effectively utilising how we're participating in those national clinical audits to improve patient care. So next slide, please. And I'll briefly update you on Kerry and Sarah's work stream. So for anybody that's new joining us today, Kerry is leading the work stream on measuring success in our local programmes, and Sarah's leading the work stream around embedding that innovation into our improvement work a lot more widely. So if we head to the next slide, we'll just touch on the measuring success in our local programmes that Kerry's leading on here. And you can see now that we're at the point where we really need our members to input to this priority for us. We've got a thread on our forum, our NQICAN forum, around measuring success, and we're going to refresh that thread for you and now move to asking our members to share your local resources so we can start pinching with pride from each other. And we are looking to hold an event later in 2024 where we'll invite some key speakers to share their resources and really inform others of how they've measured their success in their local programmes. So please do head on over. Again, I'm going to call upon the NQICAN members just to pop the link to the forum in the chat if you don't mind, please. And the real focus here is about making sure that we're sharing that whole local impact of how we're making that difference for our patients every day. So if we head to the next slide then and touch on our innovation work stream that Sarah's leading on, I think for those that attended the first webinar last year, you'll know that we're working with the Dorset Innovation Hub and the Wessex and Yorkshire and Humber Health Innovation Networks, and obviously NQICAN collaboratively. We delivered the webinar that was raising awareness to the mandated medtechs that are set out in the policy, and this is really focusing, or it was, the first webinar was focusing on utilising clinical audit as that measurement for impact on improving access to technologies and improving those health outcomes. Now this work is continuing, and we're going to hear from this work stream at the June open meeting, and again later this year when we'll deliver workshop 2. So again, please do head on over to the forum and the NQICAN web pages to access the previous recording. The links take you to our YouTube channel, and you can watch that first webinar if you didn't attend, or watch it to get that refresh. We challenged you within that webinar to really take that wealth of information away and start to think how you can adopt those technologies in practice and measure that impact through clinical audit. So it's worth a re-listen really, and think about where are you at, where is your organisation at, so that you're ready then for the next lot of information that will come out on that next webinar. So if we move to that next slide, please, lovely. And I just wanted to highlight at this point the HQIP Cornerstone 2024 Quality Improvement Magazine that came out at the end of 2023. And it's more about making reference to today around this publication as we're doing that run up to Clinical Audit Awareness Week 24. All of the articles in that magazine are fantastic. If you haven't read it yet, or you need that refresher, I would suggest accessing it via the HQIP web pages, because all of that information in there is going to give you a really good grounding as we head into Clinical Audit Awareness Week itself. It really provokes your thinking of how we can further strengthen our local processes to support clinical audit for improvement. And it does set you some challenges in there when you go to some of the articles. So please, please, please do access it. And just get your thoughts in the right place as we're starting to prepare those local plans for Clinical Audit Awareness Week. So if we move to the next slide, we were just going to utilise the opportunity today, whilst we've got you in the room, really, just to explain again about the difference between the purpose of the open meeting and that of the more local regional meetings. So this open meeting, as you're here with us today, and you'll see, it provides that open platform to hear directly from our stakeholders and other representatives of our clinical effectiveness and audit work streams. It's that two-way communication of asking questions, clarifying information to take away, and then to make sure that you take it forward in your own organisations, and also that of our partners across our systems. The regional networks offer that more local discussion then about how we're all taking these initiatives forward, our successes, our challenges, sharing and supporting each other, but also looking at how we can make those improvements across the patient pathways, across those local systems. So if we move on to the next slide, just literally touched on the regional networks, because I know, Marina, you're going to touch on it as well, but it was just to highlight really that we've got a really lovely group of dedicated individuals who are currently leading these regional networks as chairs. We know that there are a number that have deputy chairs in role, a couple of others that have got steering groups to support as well. Now, these individuals really are dedicated to the cause. We've said that here before, we're saying it again. They can't do it alone, and we're calling on more support from our network members, please, so that you can get more involved in a number of different ways. And I know that Marina's going to touch on that with you shortly, so I won't say any more at that point. But if we move to the next slide, I just wanted to, again, utilise the opportunity while we're with you just to explain about a couple of changes really on the forum, where we've put up the notice obviously to direct that discussion and support around the national clinical audits across to the future NHS workspace, that knowledge and learning hub, and we'll see a lot more local discussion and sharing around your local programmes on the forum. So they're both still serving their purpose, but more that local measurement for improvement on the NNSF and that taking action on national clinical audit, and that closely that dialogue really that we've now got with the national clinical audit providers on that future NHS workspace. So next slide, please, if we can, and we'll just highlight some events for you here. So obviously we've got the next quarterly meeting on the 5th of June, closely followed by Clinical Audit Awareness Week 24. We are planning more local events, and I know that as we do, Marina will get those announced and out to you as well. But touching again here today on a future webinar later in the year, it could be potentially July time. We've yet to confirm the date, where we'll be urging you really to have a think about Jill Stoddard's article in that HQIP magazine Cornerstone, that self-assessment that we urged you really within your organisations to undertake, so that you could see where are you at in that journey on how effectively we are actually utilising our healthcare data. So please do head on over and read that article, pick up that checklist that she's included, have a go at a bit of a self-assessment and agree within your organisation really steps that you need to take so that we are actually accessing, understanding our data in context and actually using it appropriately to actually improve patient care. So if we move to the next slide then please, conscious of time obviously, but really important that we mention here today about Clinical Audit Awareness Week that's coming up. So the dates have been announced. The launch event was held yesterday online, and if you couldn't join us, please do head on over to HQIP website to access that recording. If we move to the next slide, you'll see that we're just highlighting the Audit Hero Awards that are now officially open. We want you to go away and share this widely within your organisations and get those worthy submissions coming in. We had some fantastic ones last year, and we're looking forward to seeing what comes in this year. Number of resources that were highlighted in the launch event yesterday on the HQIP website that you can also adapt for your use locally. If we move to the next slide, you'll be able to see that we are running our daily lunch and learns again throughout the week, June the 24th to June the 28th. The lunch and learns will be running 12:30 till 1:30 every day. So please do share that widely with your teams and in your organisations and get that time protected in your calendars. The links are now available via the HQIT website, the NQICAN web pages, and we'll pop them onto the forum as well for you. Key speakers to be announced over the coming weeks as we're just confirming those with the individuals that we've approached. We will hear from our NQICAN rep for that day. We'll have a representative from HQIP joining us each day, the key speaker, and then obviously we announce that Audit Hero winner and we actually hear them present their winning entry to the audience. So we're really looking forward to this. Kept the same 5 topics because they're really, really important still for us to be promoting in terms of how we're taking audit forward to improve along each of those work streams. So as always, it's a week for us to take that opportunity to really shine that light on how effectively we are actually utilising clinical audit to improve patient care and services. So we've got the dates. We now need to start that local planning. And it was just to reflect really quickly, probably on the past few years of Clinical Audit Awareness Week, and just to think about some things that you can start to do now that will help support you within the week itself. And I think the first thing I would say would be to really strongly recommend that you gain that senior buy-in for support in your organisation for you and your teams. Who do you need to go away now and talk to make sure that you'll be supported to plan leading up to the event? You can engage those key local roles, individuals and teams. You can protect that time within the week for local events and raising awareness. It really is an opportunity to shine that light, as we've said. So which key leaders in your organisation can you engage, get the buy-in and get them to support you? Maybe think about 1 or 2 important topics for your organisation, your local community, that you can really focus on. What key messages do you want to get out? What have you already achieved? What more do you want to achieve around these topics? And then obviously get in contact with your comms team, see how they could support you to promote key messages and events in the week itself. What else could you put on locally? stands, presentations, posters, podcasts. Visit HQIP's website to access those resources that you can adapt locally. And then obviously we've got those daily lunch and learns alongside other events that will be announced. But patient safety, what could you do locally that could help to support the topics each day? So for example, who's leading on PSERF within your organisation? If you've got a key individual who could champion how clinical audit is actually supporting that learning within PSERF, it's helping to prevent avoidable harm. Thinking about PPI, linking in with your patient experience leaders, patients groups, really applying that patient voice around what matters to me, where do we need to focus our improvement work on. Health inequalities, you'll have somebody in your organisation that's leading on that. How can we help to promote that in that week so that we're starting to think about building those metrics into our local clinical audits so that we're understanding any unwarranted variation where we need to take improvement action. Influencing change, linking in with maybe those who are leading on implementing NHS impact in your organisation. How can you utilise your organisation's improvement approach to really influence taking action on clinical audit? And then obviously sustainability, perhaps link in with your informatics department and think about how you can promote more that automation of data to reduce that data burden and release that resource for taking action on national clinical audit so that we've got a more sustainable approach going forward for supporting our improvement programmes. So I'm not going to say any more because I'm conscious of time and need to hand over to Marina, but it's just, I just wanted to stimulate your thinking, I think, today to say, right, we've got a few months now in that lead up to Clinical Audit Awareness Week. So I think it's about what can we do so we've got a little bit of time to think and plan so that we can utilise that week to celebrate when it arrives. So I'll hand over to Marina and she'll give us a General Secretary update.
Thanks, Vicky. Yeah, just a short update from me today, because obviously I'm trying to let people in and manage the chat as well, so it's a busy one. Just in terms of where we're at with reimbursements, for 2023-24, obviously we're coming towards the end of the financial year. It currently stands at just under 22,000 that have been claimed in reimbursements. That includes the overaccrual from the previous year, so obviously otherwise it would have been higher, although we do still have some remaining claims to come in. Obviously, a lot of our regional networks, not everybody's organisation decides to claim those reimbursements, and obviously that is up to that employing organisation. But we do have those reimbursements available for network support time, and in 24-25, obviously we've agreed what that level is going to look like, and that does include an uplift as well for network support time. And as Vicky said, just a massive plug really in terms of supporting your regional network. Our regional networks are so vital for you to be able to have that local peer support, those local discussions as well, and that interaction in a way that you just, we're never going to be able to have on such a large sort of national call. So please do get in touch with your network, even if you can sort of offer a very small amount of time, perhaps even just help managing a membership list, or doing a presentation for the next network. It doesn't have to be a huge commitment, and you don't have to kind of suddenly step into a chair role. There's lots of different ways in which you can support your regional network, perhaps with communications, or as I say, that sort of steering group role. So so please do have a think about that, and do come forward to support your regional network. If you don't have those contact details, they are available on the NQICAN website, or just get in touch with us directly at NQICAN and we can try and put people in touch. Quarter 3 direct declarations of interest obviously were done, and I'll be starting the quarter 4 one pretty quickly. And next on my radar is the training directory, to try and get that updated. That was developed a number of years ago, so I'm obviously aware a lot of the links and things in that don't work anymore, but it is on my radar. It has been for a little bit of time, but obviously pressures of everything else. So if you do have any suggestions, any good training that you've been on, whether virtual or virtual or in person, feel free to add them either onto the discussion on the NQICAN forum or just email them to us, and I'll look at kind of adding that onto the update of the training directory when I get there. But yeah, thank you very much.
Lovely, thank you. Marina.
Yeah, sorry, and just to add, in terms of the record keeping audits webinar, we held that in January. It was a really good hour, really good discussion. We had 4 presentations from people who have been undertaking record keeping audits in their own organisations, and that recording is available. The link through to YouTube is on the NQICAN forum, and there's a couple of bits that have been shared as well on the thread on the forum. But obviously, feel free as well to add your own. Add your own tools on there or whatever that you use. I think it's just really useful for people to be able to kind of share and just get ideas from each other. No one size fits all, but if we can all get ideas from each other, it's beneficial. But that is there, available on the forum.
Lovely, thank you. And look at that, we had 30 minutes for our slot, Marina. We've brought it in with 3 minutes for questions. There you go. Has anybody got any questions at this point before we move on to the HQIP update? I know the chat's been busy, isn't it? And I've noted that there's a couple of issues with the future NHS workspace that's been highlighted. So I'll take that out today and have a look at what's going on there, and obviously the security level of the forum as well. But yeah, keep adding your chatting, because obviously we can all keep responding and supporting each other in there. Brilliant, lovely. And we'll keep an eye on the questions, obviously, and anything that we've not answered we'll try and bring in at the end as well. Fantastic. So I think we'll move over to Caroline and Kim and Helen from HQIP for their updates. So I think their slides should be next, please, Marina, and we'll hand the floor over to you.
I'm not seeing any questions for us in the chat or going up, so I'll move on to the HQIP update.
Lovely, thank you.
Thank you very much. I think it's me that's going first. Just to say good morning to everyone. My name's Helen Barron and I'm Project Manager at the Healthcare Quality Improvement Partnership. I'm going to begin our update, as I've said, and just by way of introduction, with me this morning are Caroline, one of our Associate Directors, and Kim, our Head of Patient and Care Engagement. And as Vicky said, Susan will follow us, I think, on the outlier policy. So next slide, please, Marina. Just a little bit about HQIP. So for those who don't know, we're an independent organisation and we work in partnership with patients and healthcare professionals. And our aim really is to influence and improve healthcare practice and services. Okay, I'll move on then, Marina, thank you. So as usual, I'm going to start with a very brief update on the quality accounts list, the directory, and on NCAPOP subscription activity. So the slide there is really in relation to the NHSE quality accounts list. As I'm sure a lot of you will know, the 24-25 list was published in January. And just to really flag, I suppose, that further information and updates, as always, can be found on the HQIP Quality Accounts webpage. And actually, that webpage also has the Quality Accounts list from 23-24 as well on there. Thanks, Marina. So yeah, the directory, we have released a March version of the directory, which includes the Quality Accounts List 24-25 inclusion information. The next version will be made available at the start of this coming new financial year and will include the data collection plans for 24-25 and a few other updates to some different fields. So yeah, that should be coming shortly. And again, just to flag, the HQIP directory webpage will have latest versions of the directory, further information and FAQs, which we also intend on updating soon. Okay, next slide then, thank you. So I've included this slide really just to, I suppose, highlight key aspects of the directory. First of all, and I guess most importantly, it's really for guidance and information. So the data that we include in the directory is provided by the project providers, and they give us that information at a fixed point in time. Manual updates are needed, and we do try to kind of give a refresh on a monthly basis if that's needed. But just to really flag that it's not necessarily always completely up to date at any given point. And I suppose it's sort of designed to be a starting point to some further investigation, maybe into specific detailed questions you might have or looking for further information. The diagram that I've got on that slide is really to illustrate that while the directory includes NQICAN projects and projects that are on the quality accounts list, there are other projects also listed in the directory. So it's not in and of itself a list of mandatory projects. Okay, thank you, Marina. So finally, just a very quick update on NQICAN subscriptions. We now have payment from, I think, 98% of trusts for 23-24. And just with regard to 24-25, there is going to be no change to the standard subscription fee. And we will, as usual, be writing out to trusts in April to request a purchase order for the 24-25 subscription charge. I think that's me. So thank you all very much. And I'll pass you now on to Caroline.
Well, looks like someone had a question.
Yeah, it looks like there's a question from Di.
Yeah, it's Di Lynch from Dudley Group. I just wanted to know about the quality accounts, because obviously, you know, the clinical audit teams are overstretched and got very few resources, but we seem to have increased on the number of quality accounts that we have to do. So it's put another pressure on our team to try and get all these audits completed with lack of engagement from the trust, from the clinicians. I just wanted to know what the reason behind that was.
We go through a sort of scoping exercise with NHS England, and HQIP support that process. I think you're right that the numbers of programs on the quality accounts list this time have increased. The overall programs, I think, has gone up by maybe 3 or something, and I agree that there are more work streams. We do go through a thorough sort of review and scoping process and work with NHS England to support them in delivering their priorities in terms of what's on the quality accounts list, and that goes through review and sign off within NHS England. So I suppose it's difficult for HQIP in a way to speak to those priorities. Yeah, so I'm not sure I can sort of shed any more light in terms of the strategic priorities within NHS England and how they shape what goes on the quality accounts list. I'm not sure that answers the question.
It's just, you know, they're supposed to be true clinical audits, and we've got a lot of registries on there. We've got a lot of quality improvement, like ongoing data collection and stuff. And you know, because we don't get the engagement from the clinicians, it's very difficult to get any proper improvements from the recommendations and that. And if we had a reduction in the number of quality accounts that we needed to do, we could do some proper improvements and kind of align it back to our strategy within the trusts.
Yeah, I mean, it is worth sort of noting that we are, you know, in the discussions and in the review and the sign off when the quality accounts list is being confirmed. That is something that is considered in terms of the impact and sort of making sure that that there's not being an exponential increase in those projects listed on. But it's certainly it's valuable feedback, and I'll kind of try to weave that in our planning for next year and make sure that point is sort of raised at an early stage in that process. So thank you.
Yeah, you just said there was 3 new audits. So I think there's a lot more than that, because it kind of, we've had quite a big increase. I can't say it was 3. I think it was more like 15 or something.
So Zoe's also put a very similar question in the chat, and she's commented that it's gone up from 71 to 90 as well.
Yeah.
That's the number of. Sorry, just to say that's the number of work streams in terms of the overall number of programs. I think I was thinking it was around about 3, but yeah, no, absolutely, the number of work streams has gone up. I think it's 58 in programs this year as compared to 55 last year.
But we're not getting any more resources to kind of help us take these audits forward. So it is difficult for the trust. I don't think I'm the only person that feels like this. I think there's a lot of trusts that are in the same position where we've got small clinical audit teams, and we're not able to kind of coordinate all of these national audits because it's a lot of pressure, and then we're getting pressure from our trusts as well to make sure we focus on a lot of the local audits as well.
I think that's a really important point, Di, and thank you for sharing it. It's only what we can do is to make sure we pass your message on and you know, make sure that we're sharing, that we hear what you're saying, and we will make sure NHS England are aware.
Okay, thank you.
Thanks.
Can I just add in? Just add in at that point, really, that what is really, really useful in our organisations when we're having to engage clinical teams is having a really, really clear justification of why that audit, registry or outcome review programme is really important. What's going to be the impact? Why do we really need to participate in terms of our patients and our service users? Because that is the only way to really engage our clinicians, that it's really going to make a difference to that patient group, that patient pathway. And although we get that quite clearly on the NQICAN ones, we don't always get it on the wider quality accounts topics. And I appreciate that when they put forward that they want to be included in the quality accounts list, there's a set of criteria. But I also just wonder that, is it worth feeding back as well, that it'd be fantastic if all of them on their web pages where they're hosting their national clinical audits, registries or outcome review programs, that they've got that really clear justification of how this is really going to make that difference to our patients and our service users, because we need that when we go into those discussions with our clinical teams. And as always, anything that's on the quality accounts, there's that expectation that we do participate, so we have got to find that extra resource as well. So I suppose it helps those discussions higher up the tree with our exec teams as well and our clinical leaders, because we need their buy-in to then influence those clinical teams on the front line. So anything will help us, I think, won't it, Di, in taking those discussions forward.
And then we've got a question in the chat from Zoe. Zoe, did you want to come off mute and ask it yourself, or do you want me to read it out?
Yeah, which one is it, Maureen? I think
it's how many projects on NQPOP and QA are you looking at removing? Obviously you've also asked in terms of, is there a limit to the number of work streams on the quality account, which I think is also the same point that I was making.
Yeah, sure, Marina. I understand the need for new projects. I do, but I think we have to look at what comes off the other end as well. We all appreciate, sat around this table, the clinical audit can have and how we actually use that data. But at the moment, and we just keep having, there's just new ones that keep coming. We've got 4 new cancer audits. I've just introduced or are introducing a lap section of their audit that will increase the data collection burden threefold at least. And it's who's going to collect that, who's going to input that, who's going to validate it, and the ask just appears to be increasing, but we don't appear to have anything falling off the other end.
Is it? Shall I just come in there? I think I've got the first hand up. It's hard to tell who's in order first. It was absolutely appreciate what you're saying, Zoe. And I know in our organisation we are feeling a positive move with the, and I know we're hearing from NQICAN later, but say just with the suite of the cancer audits now, because they're taking data centrally. That means for our team, we've now got a little bit of resource released to plough that into picking up that data and having those discussions about taking action. So there is something to be said around the fact that there are some changes nationally as those audits are coming up for recommissioning, where they're really thinking about that data burden to release the resource later on for taking action on data, but also having a think about within your team as well. And I totally appreciate what you're saying, and it's not that I'm not with you, Zoe, but I'm just trying to think that I know we've managed to find resource released from things such as the cancer ones that then we can now plough into things like the NELA and the NEA. So it's trying to shift things around a little bit, and also thinking about that sustainability option for trying to embed automising data where you can, especially for organisations that are on EPRs, so that again you're reducing that data burden locally.
Yeah, thanks, Vicky.
And Caroline, would you
From the
want to come in
cancer
there?
projects, isn't?
Oh, sorry, Zoe, you cut out then a second.
Oh, that's all right.
Go on. What was the comment? Something about the cancer project?
Yeah, that's not necessarily a massive burden for us in terms of data collection, because that's not us. So we wouldn't get any release there. It's when we, I think for us, it's that we end up being the funnel. We will write the reports and work with the clinicians. So as soon as we increase, that's something else for us to do. Again, I completely appreciate how important all these are in terms of patient care. I'd love to do them all and give them all the same thing. It's not that I'm saying that we don't need them at all. I understand that. It's just the impact that we have on a local basis. And I think that's kind of what Diane was saying as well.
Yeah, Caroline, do you want to come in on that?
I think, sorry, I can't remember who, sorry, I'm getting tiny little boxes with who's speaking, but there was one person who spoke that was really interesting, but the sound kept cutting out and it was about data burden. But
It was Zoe, yeah.
If there was a question, I can come back to it. I think I was going to say, so a large number of the increase, I think, this year is the cancer audits, which are going to, I won't steal Julie's thunder because we're going to hear all about those in a minute, and the routine data collection. Right, there's a question, Stephen, here. Yeah, how often they decommission? Well, so every time an audit it comes up for commissioning, that those questions are asked, and there is this specification development meeting, and is this relevant to patients, and what needs to be in and what needs to be out, and NQICAN always have a seat at those meetings, and those are the places to raise it. And I guess we could say that they always reflect national priorities and try to, and are put in place in response to that. Yeah, it's probably as far as I can go on that. Shall I carry on with the slides and then we can come back to any questions? Is this the first? Sorry, I've lost myself slightly. Is this the first slide after Helen's presentation?
Yeah, this is
Great.
this is
Okay.
you, Karen.
We're back on. Right. Oh yes, I can see it in front of me. Right, thank you. Well, to continue on the subject of tenders, so there is a new audit, the National Audit of Eating Disorders, and it has been evaluated and the award is imminent. So probably a very different selection of patients and services for that one. And then the Mental Health Clinical Outcome Review Programme has been recommissioned, and that award is also imminent. So that's been our procurement activity since the last meeting. Could I have next slide, please? Yes, so on reports, many people know, but if you didn't, HQIP and all our providers release our reports with very few exceptions on the second Thursday of every month. So you always know when they're coming. There is an exception in April, and that's because of the pre-election period. They're coming a day early on the 10th of April, but normally the second Thursday of every month. So that's when you can expect to see the reports. They're always listed on our website. We haven't listed on the slides because there's quite a lot, but what we do after this meeting, as usual, is there's a PDF document that lists all the links and all the things that we're saying that can go out. So you have all the links and on that. So we've drawn a couple of reports out onto this slide, but all the reports are there for everybody each month. Could I have the next slide, please? Oh, we must have missed it. I've got more slides on my own presentation. Sorry.
No, this was the version that was sent through
This
to
is the
me.
version.
We haven't got
Feel
another
free to-
slide.
There's a couple more slides.
Yeah, there's several more
Look, who
slides.
knows? They've been lost along the way. I can still talk to them. Right. Let's go. Well, I was simply going to say that the CVD Prevent, so cardiovascular disease, that audit was quite a large program. It's of primary care, so probably a slightly different audience. The team have just announced 10 new experimental indicators on outcomes, so a completely new type of indicator that's been calculated and being used. Now we think it's quite an exciting project, so there'll be links in the there'll be links in the document that comes around, and people can find out more about that. But just to flag that new piece of work. And the next slide I was going to talk about was the NCAB platform, and recently data has gone on to the NCAB National Clinical Audit Benchmarking from the National Joint Registry and the National Neonatal Audit Programme. This is the platform. It continues to be updated with the CQC provide the updates. And I also want to flag that outlier guidance was published. New revised outlier guidance was published by HQIP for all of our providers in January, and there are quite a few changes. And if I'm right, is Susan going to be presenting a bit more detail, Vicky?
Yeah, she's
yeah.
on
So
after
I won't say what Susan's going to say. But the links are all there in our pack that will come around, and Susan will go into some more detail. And with that, I think I can now hand over to Kim. Thanks.
Right, so can you see my screen and my slide?
Yes.
Yeah, okay. So I feel like I'm repeating everything Vicky said, so I won't go into this. You know, it's open. We had the launch event yesterday with Danny and Chris, launching the awards, which are now open until the 5th of May. All the information is on our website, and there's also a toolkit online to support sharing and organising local events. So please keep up to date on our e-bulletins, and comms will be most annoyed with me that I haven't changed that Twitter sign to X, which I must do for the next one. So please get planning your activities and start sharing using the hashtag CAAW24. Also a repeat on Vicky, so I won't go into it. We have our Cornerstone magazine, and there's an article actually that Caroline wrote about the NQICAN, and you'll be hearing more about that later. We also have published case studies from other audit hero categories. So we've got the healthcare inequalities commended entry from Michaela Wardle, Senior House Officer at Sandwell and West Birmingham NHS Trust, published online, and also influencing organisational change case study from Amy Baker, Cambridge University Hospitals, the winner in this category. So all found on our website, and we will be putting out update onto the forum with all these links. And just final slide on patient and public involvement. So we as of today will be handing in our completed documents for the HDR UK funded project, and this was to develop resources to support the recruitment of public members onto our data access request group. And for the project team, we included 3 Sun members, service user network members. And whilst we involved Sun in lots of our projects over the years, this was the first time that we actually sort of recruited people to join our team, and the project was over a period of time. So it was a really good example of collaboration and co-design, and we really enjoyed it. We will be putting information about all of this on our website. We also, you heard Vicky mention the dementia audit. So before the specification development meeting, which I think was last week, we held a focus group with people with lived experience of dementia to hear about their clinical priorities. But we also focused on the patients and carers surveys to ask about their views on taking that forward. And I will be obviously taking all those views into the tender process. We also held a webinar earlier this month looking at engaging patients and carers in our national programmes. So we heard from 4 projects: the Falls and Fragility Child Mortality Database, Paediatric Diabetes, and also the Maternal and Perinatal Audit. 4 of them came to present about what they do, so different methods of engagement. And we also ran a focus session on creating infographics, and we had our service user network members there for that as well, so that was really good. So the usual information about our available resources, and for you to let me know about any work you're doing. I'm looking forward to seeing some really good entries in the PPI category for Clinical Audit Awareness Week. So thank you, and I will stop sharing. Any questions?
There are some questions in the chat, and but I'm not seeing any hands go up at the moment. So there was a question in the chat about if somebody could describe the difference between a work stream and an audit. That was when it was Helen's presentation.
Shall I take that?
Yeah, when you go if you want.
Although Helen, I think you probably know it better than me. Let's give an example. Like the Falls program, the Falls and Fragility Fractures program, the whole program. Would you call that one audit, Helen?
Yeah, that's the program or project level, yes.
But
And
within
then
that, there are some different work streams.
yeah,
Let's take the respiratory. There's another one. The respiratory audit program is called an audit program. That's an audit, and within that, there's There's asthma, there's pulmonary rehab, etc. So there's
and there's different age categories as well.
Yeah. In some cases, yeah. Yes.
And there's some comments about resources. Vicky's put a point in about when resource is an issue, I'd encourage NCPOP first and foremost, then wider quality accounts. Consider resource to local topics and undertake an analysis of resources and feedback to execs. Do you need an organisation response? And a similar comment from Zoe as well. Perhaps a directive from NHSE for acute trust to ensure they have adequate establishments within clinical effectiveness teams to support increasing programmes for NCPOP and QA, as well as increase linking to patient safety incident investigations and other governance intelligence would be benefit for teams locally. It will be helpful if HQIP could take this back to NHSE. Did either of you want to comment on that?
Yeah, just to say yes, noted, and we will do. I'll gather some of this feedback actually and chat to Caroline and figure out the best way of communicating that back. So thank you all very much.
Yeah. And then we've got a comment from Craig. Is there any evidence that details the VFM of the NCPOP programme to organisations? Craig, I don't know if you want to take yourself off mute for this. If he's able to. I can see we've got hands up as well. I'm just working my way through the chat.
I think Craig's comment was just about value for money. I think we obviously have the NACPOP programme impact report that gives some highlights, don't we? So I wonder if Craig's pushing for more. Is there anything more that could really help to evidence that for us? Because again, that helps us within organisations as well, doesn't it, to take those discussions forward?
Yeah, it's what's been said in a few different points, isn't it, about making sure that we've got that, that information that, what is the impact of these audits, particularly when there are more to, to manage within the resources. So you could include that in your feedback as well, please, Caroline and Vicky. Caroline and Kim, that'd be good.
Yeah, it's interesting.
Okay.
I mean, without national audits, there would be no national benchmarking. So I mean, there's value for money at trust level, there's the national system, that these things all into play.
Yeah, and obviously you've commented in the chat as well, many of the audits are moving towards routine data collection, e.g. the cancer audits, which obviously we've got on our agenda for today. Yeah, there's a recommendation to read the Cornerstone article. So I'm just looking for the comment, looking for the questions in particular. There's quite obviously a bit of discussion about the data burden. So on hands, then we've got Stephen.
Thank you, Marina. Happy Easter, everybody. I just wanted to ask, it's a really good chat today, thank you. I just wanted to ask at the other end of the audit process, obviously around the sort of the turnaround of results, and we were really lucky last week to hear from Stella Vig at a conference we were, Tracy and I were chairing, but she made a comment that data from national audits, it was 12 to 18 months and presumably beyond. She described it as, I think she said, it's not much help, and she said that there's a lot of review going on to obviously speed this up. I just wanted to find out what people think. I'd be interested to know what NQICAN think, and obviously from the HQIP perspective, what's the advice to clinical audit staff when they're getting national audit reports that are focusing on data, say, from 2021? I know I've looked at the national maternity and perinatal audit, which is obviously a very well-known one. their report in June 22 was from data looking at April 18 to March 19. So some of that data is 3.5 years old. So like, is it ethical to say to clinical teams, here's some data from 3 years ago, you need to change practice if it shows some substandard care, or just I'd just like to know what the viewpoint is, and it'd be interesting to hear from people on the call what they're doing with national audit data. That's obvious, and I know there's a move to speeding it up, but there's still going to be a lot of lag on that in terms of moving it forward. Thank you.
Yeah, I can take that first, Stephen, if you want me to, before perhaps ask HQIB to support responses. Really, it is really about your local process as well. We know as the national audits are coming up for recommissioning, there's that push now for that more frequent data feedback. Now, I am really valuing the NQICAN programme now in our organisation, and it's about you getting your local processes in place. So actually, it's not just about putting that data in, it's watching the data come back out. Now, with the data dashboards, these are coming out really frequently, and we are seeing more real-time data, not for all of them yet, but it will be going in that direction. I think for the ones where at the moment we're seeing older data published, what is the capacity locally? And it will depend on each audit in terms of how you're submitting that data. If you actually understanding that local data set that you've already submitted, because really if you're on top of your data, you can already analyse that locally so that you know if you've got any risks, if you've got any concerns that are of significance, and you'd hope to see that continuous improvement plan behind the data that you're continuously submitting. So it's about strengthening those governance and response processes that you've got in your own organisation. And I know Susan's going to talk to us about the outlier policy, and it'll come up in our discussions post that talk as well. But we should know where we're at any point in time with our data, so we will already know if we've got a concern before we're even flagging as that outlier, and we should already be putting those improvement actions in place to address. So no, there's a lot more sharing needs to go on in terms of what local processes are for effectively participating in national clinical audit. And it's not just about getting that good quality timely data in, it's actually, do we know when we've got access to that data, and have we got access to what we've submitted locally if we know it's not going to be published for some time? I'll let Caroline come in though.
Yeah, such a good discussion to, sorry, go on.
Yeah, no, I was just bringing you in.
Oh, thank you. Such a good discussion to have, and one we regularly have, because obviously this is important to all of us. So would raise so a few points. I mean, to repeat what Vicky said a little, all of the audits now possibly, or certainly nearly all of the audits now will have the requirement to produce these quarterly data dashboards, so much more up-to-date data. That's one set of data, and it's often rapid data. And Julie, I know we'll talk a bit more about this in the cancer later on the agenda. However, there are also big pieces of work that go on, that why it takes longer to get hold of the data sets that yes you enter or come out of routine data, and link it to all these other data sets that from Office of National Statistics, the HES data and everything else that goes on, to link individual patients and outcomes. Some of those are necessarily take time, like a 2-year mortality figure will obviously take more than 2 years, and some of them are only released once a year at the end of the year, so you have a denominator, because you need a denominator in order to calculate some of this. So necessarily some of that takes some time. Some of it takes some time, and we all know there's a few delays in the system about getting data back out, and I know Julie might be able to say more about that. So, and then it takes time for the audit teams, although they always have very little time compared with how long it takes to get the data out, to validate it, check it, and get it back out and produce it into a report, which they do in a matter of weeks. And then it gets published in the normal way. So those are the reasons why. But I would say the places to go are those quarterly dashboards for more recent data, and then once a year that state of the nation longer term data that's linked, compiled, benchmarked, etc.
Can I just come back?
We've got a nice link from Lara, thank you, on the respiratory audit, which are doing all sorts of nice things with their data and publishing them regularly and updating them regularly. So I do encourage you. I'm thinking of organising, I just talked to Julie Noster about it yesterday, that something for Clinical Audit Awareness Week on using the quarterly reports, doing a session on using them, investigating them, the data, the various dashboards that there are, and the access spreadsheets to really spread that knowledge that we are not. It's not the case that we're waiting 2 years anymore. Those data dashboards are coming out regularly, and to try and demonstrate how those are being used. So hopefully that'll be useful to people.
Stephen, did you want to come back in, and then we'll go to Zoe briefly?
Yeah, sorry. It's just that there is data out there, and I appreciate what Vicky's saying, but it almost feels like we're submitting data nationally, but we should also know exactly where that data sits at the same time as it's going through. And I guess and I appreciate we're measuring against standards mainly, but I think what's really valuable about national audits is you get the aggregated data back, and that's what obviously sometimes takes a turnaround time. It's what I said previously though. For a clinical team, are you comfortable going to a clinical team with data that's 2 years old and actually advising them in terms of whether they should change practice? Because that's what's happening with some of the national clinical audit data as it currently stands in terms of the time lag coming back to teams.
And we're not recommending that trusts do that. I mean, there's some great work, like all the work that Sam Riley's been doing on the Making Data Count, so that you've got those trends. You can set your own control limits. You should be putting your own systems in place, like Vicky was saying. Report back. What the national data does is something different. That's risk adjusting and benchmarking. It's for a different purpose.
And then can we have Zoe in next, and then we'll go to Di afterwards. So Zoe's, go on for it.
Sorry, Marina, thank you. So my question was around the reduction in criteria. I had a conversation with Susan Gillespie earlier this week, and she was talking about how they are looking at reducing the number of criteria that's collected, and said that we should see that coming through, which I can't say that I've seen that yet. Is there an example that you can give of where the data sets have been reduced significantly to help us with the data burden?
Yes, all of the new commissions have the general specifications now are to focus on 10 metrics per audit, which is a substantial reduction for some of them, and is really aimed to both reduce the burden but also increase the impact, so we can really focus on improvement activities for the year.
Thank you. So
all of the cancer audits, for example.
What about the older one, lengthy data collection? Obviously never spoken about with their no lap. I think there's items that needs collecting for the no lap audit.
Sorry, what's no lap?
No, the emergency laparotomy audit. So initially it was just patients that had an emergency laparotomy, had the operation. Nella have now put a no lap in, so where the patient was considered but then didn't have the operation.
Sorry, I couldn't hear very well. Yeah, that's an additional piece of work that's been done for Nella, isn't it?
Yeah, but that's like I say, that's the thing that we need to stop, a new thing that we need to find someone to collect that data for and get that validated. But there are 58 data items to collect. It's quite a lot to then add. So if these substantive audits are increasing things, are they held to the same account? You know, like you've got to the older audits to start reducing their metric.
I think
I'm really sorry, I didn't catch all of that, but I think the question was the older audits, and the answer is that one by one, as they come up for recommissioning, that the new requirement is to go to the 10 metrics. So you will see that coming through fairly speedily now. I guess there's still a few on the old contracts that are still running with them, what they have been doing for the last couple of years.
Yeah.
If it's a new, I didn't know about the 58. I'm very interested in that, so I'll go and find out a bit more. But sometimes a new work stream is added. I mean, not very often, but I'm afraid I don't know what this that it was 58. But I'll find out, and I'll see what more I can find out about that.
In the interest of time, we do need to move on to our next speaker, Susan. But if you do have more questions, please put them in the chat. And Di, I'm sorry, but I know you were wanting to come in as well. We'll put it on the Q&A at the end of the session if your questions are not answered in this time as well.
Okay.
Just reshare my screen then for Susan. Victoria, do you want to introduce Susan?
Yeah, sorry. So Susan's joined us from HCIP, Susan Gillespie, just to really give us a bit of an update and a highlight on the key points really within the refresh of the NACPOP outliers guidance. So we'll hand over to Susan, because I know we're going to have questions on the back of this one as well. So over to you, Susan.
Thank you very much, and thank you so much for having me back for another meeting. That's been great. So as was mentioned, I'm a project manager with HQIP. The core part of my role is in helping to make the audit data available on our NCAD benchmarking platform, and I work with CQC and the NQICAN providers on that work. Also on the outliers, which I'm going to be talking about today, but I do also help out on some other projects, which is why some of you have been seeing me pop up in sort of different contexts recently. So if we can have the next slide, please. So it was quite a while before my time in HQIP, but I'm reliably informed that the first sort of guidance document that was produced about identifying and reporting outliers was around about 10 years ago. Since that original one, there have been some updates. Most recently, that was around COVID and aimed at sort of cutting back on the requirements for outlier reporting, obviously to allow for the necessary shifts in focus and resources around that time. As we came out of that phase and started to ramp up again with the outlier reporting, Danny Keenan, our medical director, decided to lead a review of the outliers guidance, and that happened over actually most of 2023, and we worked with all of the partners with that, so CQC, Welsh Government, NHSE, and our providers. And that was published, as mentioned, in January of this year on the website, and also up on the website there is a table of changes. So if people have been working from the older version, they can quickly see what has changed on there. One thing that I do want to note at this point is that the providers don't work directly from this guidance, so they use it to inform development of their individual audit policies. So there is some scope for change and adaptation as it works across the different audits. If I could have the next slide, please. So just to go over the sort of overarching aim of this review from Danny's perspective was to make sure that we had a focus in this policy on using outliers as a part of quality improvement and not policing, to quote Danny. So this included starting to think about the potential of looking more at positive outliers as well. In terms of sort of the operational stuff, we wanted to just streamline and clarify the notification processes for the alert level alarms, which is the 2 standard deviation, and the alarm level, which is the 3 standard deviation in the statistical analysis. And I think probably one of the biggest changes in terms of actual policy was that in this newest version, we have asked the providers to include non-participation in the outlier notification process. So where a trust is eligible for an audit but haven't submitted any data, they will be flagged and reported through the outlier process. We expect the new guidance should be applied in full for any audits that are beginning this year, but where possible, we have asked the audits to adopt any of the changes if their audit's already underway, if it's possible to. So that will include things like using the new template and if they can, following the updated notification process. So that's it. If I can have the next slide, please. So just to get into some of the details, some of the specific changes that we've made is that NHS England will be included in the notification process in a different way. So previously, they received a quarterly summary of the outline notifications from CQC. They will still get that, but NHS England have asked now to be included in the notifications when CQC gets them as well. So as each individual audit sends through their collection of outliers, that will go to NHS England as well. In terms of the alert level outliers, so that's our our 2 standard deviation outliers. For England, CQC and NHSE have requested that they will only be notified of those for metrics that are related to mortality. For the Welsh Government, they've asked to continue to be notified of all those alert level outliers. Just at that point, I think it's important to just note that obviously all of the data included in the audit reporting will be made available regardless of these notifications. So it's not like that information is disappearing. it will still be there as part of the audit reporting. It just won't be sent as a specific notification. So we have a new outlier template, which we hope will make it easier for the audits and for CQC and those receiving the notifications to understand why metrics have been selected, what they mean, the interpretation. So all of that information should be standardized now. And as I mentioned, those non-participating outliers where they've been identified by the audits, we've asked those to be processed via the same process for the alarm level outliers, but they will be sort of clearly marked as non-participation outliers so that is clear in the process. So if we could pop on to the next slide, please. So I wanted to try and pull out a sort of high-level summary of how the notifications work, because I think that is of interest to this group. So this sort of misses out a lot of the detail, obviously, but I hope it gives a helpful summary. So for those alert level outliers for England, on the left there, this is mortality only, of course, and that goes to CQC, NHS England, the HQIP teams and the lead clinicians. And for Wales, that goes to Welsh Government and the HQIP team. So for those alerts, there's no formal escalation notification process, written letters, those sorts of things beyond that sort of lead clinician level. For alarms on the right-hand side, the first step in those is that the lead clinician is notified so that the data can be checked. So the first thing is that they verify that this isn't a problem with the data, that there is actually an alarm level outlier there. So if that is confirmed, the lead clinician is given a sort of heads up phone call first before there is a written notification which goes to the healthcare provider CEO, medical director, and the lead clinician there. And then the same situation for England and Wales. So for England, it goes to CQC and HSE and the HQIP team, and for Wales to the government and to the HQIP team. For the alarms, one of the things that has sort of formally changed in this version of the document is that there's no requirement for a sort of formal action plan, an official written response to that alarm notification. But what we've been asked to include is that if there is an investigation within the trust, that if the CQC and the audit providers can be informed of that and any outcomes or any proposed actions. And if the trust wants to provide a written response, then we will also work to make that available with the audit team, because previously I think they were asked to provide a written response and then that would be included in the audit reporting. But as that process is sort of more regular updates and things, we can find different ways to make that available on websites and things. In Wales, there will still be a request for a local investigation, and the Welsh Government will monitor that and share that as required. So that's a very brief whistle stop. That's all I had for today. The only other thing I wanted to say is that as this is being rolled out, we're monitoring the feedback. We've had a few questions come through from the audit providers, and we'll be taking those into consideration as we sort of plan for potential updates in the future and sharing more information about that. So I hope that's been helpful. Let me know if you have some questions.
Thank you, Susan. We've got a comment in the chat from Zoe. Zoe, did you want to bring yourself off mute to raise in terms of the notifying the clinical audit team?
Has already kind of said here. Sorry, I get the feeling that people are going, oh God, it's her again, and I do apologise for that. I have raised this. We have raised this at Yearn, and Vicky has said that this has been escalated as well. But when you actually look at who are getting told about these alerts and alarms, with it going to the lead clinician, I understand that is the right person for it to be sent to, but you have to let the clinical audit teams know as well. When it comes to facilitation and the data quality and the data validation, that sits very firmly at our door. The lead clinician would not start that, we would. And the sooner we know about these alerts and alarms, the sooner we can take action to do that data quality review and put some investigative and responsive actions in place in relation to that. We have report, and it's all the work that goes on around the outliers, any additional audits to deep dive into certain criteria, anything that we need to do to sort of like put some quality improvement in place to stop things, whether there's business cases that need to be written, all that is pulled together by us as facilitators. And I think that's why it's so important to let us know as soon as possible.
Sure. I think Caroline may have some more detail on this, but I have been speaking to the team because I knew that this is something that had come up before. And my understanding is that it's sort of a question of maintaining information or a list, or how do we know who the right person is to send that to? I think because there are those structures in place around the audits where the so the lead clinician is part of that sort of system, that's been easy, but it's how we know where to send it apart from that. But I'm going to let Caroline talk much more articulately about that.
I think I was going to say the same. I don't think there's been any, actually Julie Noster might have more perspective on this from a provider's perspective when she does her talk, but I mean, there's been no appetite to exclude anyone. It's just a simple case of logistics and getting the right lists in place. And I guess that's something that we can take away. Yes, exactly. Generic or email addresses that are good. Yeah, I suppose that's all I'd say about that is making sure that contact details remain the same, and that it's a practical thing rather than anything else. I would
Sure. And in terms of practicality for this guidance, I wonder if that's something that we can just request that the audits put in their outlier policy, because I think that's something that would be very difficult to cover in terms of every audit that's going on within this guidance. But what we could potentially do is say to the individual audits, as part of your policy, you need to identify or find out the person or the generic email where that could go to potentially.
It sounds really sensible. Julie, you'll know more about this than me.
Yeah, I think that's a really good idea. And I know from a sort of an operational, so for the audits, for example, using prostate cancer audit, which I've worked on for a number of years. So we tend to bring in you guys when we don't have a response from the clinical lead. So I think it's really good. I think that's a really good suggestion to include you earlier. I think what would be helpful, and maybe this is something that HWIP can organise, is to ensure that there's an up-to-date list for every trust of a contact from audit or clinical effectiveness, because we have for some in our contact databases for the different audits. We have we have contacts for some trusts, but not for others. So I think maybe if that's something HQIP could organise that we could then access, that would be great.
And Di, your hand was up, and then is it going back down again?
Yeah, so Zoe asked the same question I was asking.
Okay. Yeah, and there's a couple of comments in the chat as well in terms of in terms of that same thing, saying about how useful it would be for those alerts to come through to clinical audit, clinical effectiveness teams, and an example I think that also Lauren has put in the chat where something was discovered 9 months down the line, but where action hadn't been taken because of the clinical audit team not being made aware. Vicky's asked the question, can we mandate it for the NCPOP ones?
Is the question at us?
Yeah,
probably don't see why not. I mean, I will take that away. Susan, any thoughts?
I think, again, it just comes down to how we capture the right place to send it, I think, and how we manage that and make sure that's up to date. So I think that's something we can definitely discuss across the NQPOP processes and the providers.
I mean, let's take that away. Is there any? I mean, there's something about having a named person who really is responsible for it, isn't for something, and that it's their job to disseminate within the relevant organisation. And Sarah, you put some interesting information there about being involved, a lead clinician being involved. Totally agree. Yeah, okay, we'll take that one.
Yeah, I think there's there's a couple of comments. Karen, Sarah. Yeah, also basically it's agreeing the same point. I've got one here. It would be useful from HQIP to provide a link on their website where people could sign up with local clinical audit teams' email addresses for notifications about outliers. So if whether there's a portal on the NQICAN site where people could say this is the contact details for the clinical audit team at our trust. It's a useful suggestion. Yeah, and then Lara's put the process in MRAP is to contact the lead clinician first before it's escalated. But I think what clinical audit teams are feeding back is that it would be useful for them to be made aware from the outset to kind of avoid those delays happening in the first place. Okay,
I presume this occurs once an outlier is being confirmed. Yeah.
Yeah.
Aren't those letters? I'm going to go really off piste here, Laura. You'll know more than me. Those letters are put in the public domain, aren't they? So I'm struggling.
No, they're not. They're not.
No, they're
in the
not.
public
Okay,
domain now.
fine. I mean, yeah, Julie might comment more. I have seen ones that sometimes are in the public domain. So I was thinking, surely if they're in the public domain, the trust knows all about them. But
okay, I'm not seeing any further questions or hands up. Nope, I think they're all sorted. So should we move? Oh, Vicky.
I just sort of thought the other thing as well is locally putting in that agreeing as an organisation that SOP, that local SOP for responding to outlier status, which might be right from your lead clinician being informed, because which comes back to your comments there about the governance, isn't it? So actually, if you agree that locally and the comms is right in your organisation, because I know there's been letters in some organisations go to medical directors and they don't filter through to the clinical effectiveness team. So I think this is how this all arose to begin with. But I wonder if you need that local escalation SOP agreeing in your organisation. That might help as well.
It's an interesting comment from Zoe saying the NHFD told us specifically they were not allowed to notify us, which is interesting if that's the message that perhaps some perceiving.
Yeah, that's why I'm hesitating to say let's find out a bit more and see whether there's any sort of clinical governance rules around this. I will take it away.
Thank you very much. Oh, and Zoe, and then we will have to move on to the next speaker.
Yeah, sorry, it's I just think it's so important. It's like these emails come in generally, and sometimes I'll go to my medical director, the chief exec, or the lead clinician, and it really does set the hairs racing in lots of different directions and for very good reasons. Then trying to get them back in line so we can kind of facilitate that response then becomes very difficult. If we are notified right at the start, then we have more of a chance of keeping this response really ordered, that there's less duplication of work, that people aren't being set off all over the place to do different things and we lose track of it. It is very much about pulling it all together and having a considered response that is impactful in terms of improvement. I will promise I'll be very quiet now. Thank you very much.
Can I just add one more point on that? Because I think it might help for clarification. I think potentially with the NHFD thing and the reason why these have previously been sent to very specific recipients is because of the outliers notifications were coming out prior to their sort of report being officially published. So I think it was sort of managed in a stricter way because of that sort of hierarchy with getting the publication and the data being publicly released. We're working on that happening all much closer together in the future, but just for clarification, I think that might have been why some of them were sticking very closely to the particular notification processes.
Thank you. So I'll stop sharing my screen now then, Vicky, if you want to introduce our next speaker.
Lovely, thank you, and thank you everybody that's presented so far, and obviously everybody for their questions as well. There's some really valuable discussions going on this morning, which is brilliant. Please keep putting in the chat, because as we said, we will collate everything. Things that we don't get a chance to respond to today, we will go our way to get responses to. So this is your opportunity to get your questions in. Right, I'm going to hand over to Julie and Karen now that have joined us from NQICAN, and yeah, look, utilise our audience today to get all your key messages across, and I'm sure we're going to have some questions for you as well. Thank you.
Okay, thanks Vicky, and thanks Marina for inviting us to attend the meeting today, and thank you Caroline for putting us in contact. Can you see my slides? I can't see you guys. Can you?
We can,
yes,
Julie,
yes.
yes.
Yes, you can. Thank you.
Yeah.
Okay, so I'm Julie Nossiter. I'm the Director of Operations for NQICAN. I've been working in national cancer audits for over 10 years now. Started initially on the prostate cancer audit. And I'm also joined today by Karen Darley, who joined us just before Christmas as Senior Project Manager for the OG and bowel cancer audits. So the National Cancer Audit Collaborating Centre was commissioned by HQIP. It's funded by NHS England and the Welsh Government. So there's funding in place initially for 3 years. The centre started on the 1st of October 2022. So NQICAN aims to provide regular, timely evidence to cancer services of where there's variation in care in England and Wales, and to support NHS services to identify reasons for this and to help guide quality improvement initiatives. And with our end game is to stimulate improvements in cancer detection, treatment and outcome for patients, including survival rates. So NQICAN is now the home of the 10 national cancer audits in England and Wales. So the Clinical Effectiveness Unit at the Royal College of Surgeons was commissioned to deliver NQICAN. And the existing audits, the existing cancer audits in OG, bowel, prostate and lung, which were already being managed and run from the CEU, moved into NQICAN under contract variations at different points last year. So I'm sure a number of you are sort of familiar with the Clinical Effectiveness Unit. The Clinical Effectiveness Unit also runs the National Vascular Registry and the Crane Registry as well. We've been working on national cancer audits for almost 15 years now. The Clinical Effectiveness Unit itself, it's a multidisciplinary partnership between the Royal College of Surgeons and the London School of Hygiene and Tropical Medicine. And that partnership's been in place for 25 years now. So we've worked on a number of sort of large-scale healthcare improvement and performance assessment projects in that time. So this is just to show you that as part to, this was just launched yesterday to sort of mark the move into NQICAN. the existing audits have undergone a rebranding exercise. So it demonstrates how we're all part of the same family, all the cancer audits. So because of the experience in the Clinical Effectiveness Unit, we've got a lot to take forward into NQICAN. So the NQICAN maintains the key features of the existing audits. So we're applying those to our new audits in ovarian, kidney, pancreatic, primary and metastatic breast cancer and non-Hodgkin lymphoma. There were 6 new audits. So we're applying this knowledge that we've gained from the lung, the prostate, the bowel and the OG audits over the years. So each audit is led by a multidisciplinary team of clinical experts. So these are our clinical leads representing the professional organisations. And we also have senior academics from the London School of Hygiene and Tropical Medicine. So they have expertise in clinical epidemiology and statistics, data science. So this ensures that we ask the right questions about cancer care and treatment, but also we use the right methods to answer those questions. So each audit collaborates closely with all relevant stakeholder groups to inform the quality improvement priorities. So this includes professional organisations, as I mentioned, patient charities and patients or people with lived experience of cancer, I should say. And each audit has a standalone clinical reference group with representation from all key stakeholders. So the approach that we take, we say that audit and delivery and quality improvement, it's important that this is informed by research and development. And by that, I mean, and Caroline alluded to this earlier, we ensure that we carry out methodological development so that our performance indicators are clinically relevant. So this makes our outputs more robust. We take a clinical epidemiological approach, so we investigate what the determinants of variation in practice and outcomes are. So this guides our outputs and it ensures that these are more informative for quality improvement. it's also essential to have an understanding and to apply a health services research approach. We have to understand what the structural organisation of cancer services is, who's providing care where, an understanding of hub versus spoke hospitals, for example. So this enables us to target quality improvement initiatives appropriately. So there's a number of innovations in NQICAN. We've applied for one single data application. So we use routine data only, and I'll talk about that in a little more detail in a moment. So we just say previously each individual audit had a separate data stream. So we've now applied for just one single set of data from the cancer registries. A key innovation is the use of rapid cancer registry data. So the existing audits in lung and prostate have used gold standard registry data over the years, and this is available. There's quite a long lag, and that I absolutely agree with the points that were raised earlier. There's quite a long lag. So, for example, for the 6 new audits in NQICAN, we received gold standard cancer registry data in January this year. That's the most recently available data, and it's only for patients up to the end of 2021. So a huge lag. A key innovation is this availability of what's called the Rapid Cancer Registry data set. It's a much shorter list of data items, and it's available 4 to 6 months after diagnosis. So this more rapid data is what we will use for our quarterly reporting. So there'll be more frequent, more timely reporting. As Caroline mentioned, the cancer audits, like across the new audits that have been commissioned as part of the NQICAN programme, instead of a big, long, lengthy annual report each year, we've moved to reporting State of the Nation reports. So these are 10 pages maximum and include only 5 recommendations. And being able to use this more frequently available data, and that absolutely is I'll say again, I absolutely agree with the points raised earlier. More frequent reporting will enable us to, I think, for the cancer audits to close the audit cycle for the first time. So we can report results and use those to drive improvements and then look to see where improvements have been made. So since the beginning of October 2022, we've been incredibly busy. We've made a lot of progress. We've set up the centre. We've developed our communication strategy, which Karen will talk about a little bit more in a moment. I mentioned about data, a common data request across all the audits. We've set up the 6 new audits, and the 4 existing audits have moved into NQICAN. In the first year, we started to recruit for each audit has a standalone patient group, patient forum. And with the exception of 2 of the audits, each of the audits has held their first meetings. We've been working closely with the patient charities to recruit. We also carried out an exercise of scoping for the 6 new audits, and then also scoping for the future direction of the existing audits. So that was a key activity, working with key stakeholders last year, and to determine which of the 5 key quality improvement areas that the audits will focus upon. So in the second year, we're very much focusing now, moving to reporting for the 6 new audits and developing and implementing our quality improvement strategy. I won't go into detail here, but this just is a sort of demonstrates the organisation of NQICAN. So we have an overarching board, there's an executive team. Each of the 10 cancer audits has their own project team. They each have their own clinical reference group and patient panels. So we were lucky to, we recruited for a clinical director, and following a competitive recruitment process, we were lucky that Professor Ajay Agarwal took up that post in the autumn. Ajay has been working I initially started working with Ajay on the prostate cancer audit over 10 years ago. He brings a lot of passion and care and expertise into NQICAN. And he's already implemented a number of changes and is very much guiding our clinical strategic direction. So this infographic just gives you some idea of like who we are and sort of the breadth and depth of the collaborations and the partnerships that make NQICAN possible. So I mentioned about data. I think it's key that I just wanted to raise that the audits use routine data only. So there aren't the only cancer audits, OG and bowel cancer audits, that had a bespoke cancer data platform, the CAP system, that's now closed. So the audits will now use routine data only. So there is no longer a requirement for submission in using bespoke data collection platforms. However, within the hospital trusts, either yourselves or members of your wider teams may very well be involved in the collection of the cancer outcome services data set to the cancer registry. So that's the sort of source, that's where we get our diagnostic cohort of patients, and that is then linked to different data sets such as HERS and such as the SAC data set and the radiotherapy data set. And we take a similar approach using those data sets that are available in Wales. So before I move on, I just want to check because I can't see anyone on the screen. Can you still hear me? Am I still sharing my slides?
You are,
Yes,
Julie.
you are.
Thank you. That's fine. It's a bit disconcerting for some reason. I can't see you all. So I just want to make sure I wasn't talking to myself. So I just wanted to just present this slide here, which just sort of illustrates the approach that we take. So we use routine data only. So we all want to, what we've been talking about here is we want to drive local quality improvement. We want to understand what the variation, why there might be variation in care, what are the drivers of that. But before that, we have to use the routine data appropriately. So we develop indicators. So we want to make sure that we can accurately measure care. So you can imagine this takes quite a bit of time, especially with the new rapid cancer registry data. So the gold standard cancer registry data case ascertainment is 100%. It's not 100% in the rapid data, purely by the nature of its of how it's prepared and how it's available much sooner after diagnosis. So the great deal of time that the cancer registry put into developing the gold standard data isn't applied to the rapid data. So we have to make absolutely sure that we're using that data, which it's brilliant, it's available sooner, but there are some data caveats. There is some large levels of missingness for some of the data, for example, such as staging. So we need to do some methodological development work, because if we're going to be reporting back to trusts where improvements are needed, we have to be absolutely sure that what we're reporting is correct. We need to make sure that we carry out risk adjustment to carry out fair comparisons. And we need to make sure that we use the right methods for reporting and use timely, reliable feedback, as I mentioned, and that we have appropriate statistical power. So it's all about reporting robust results. So we published, if you haven't seen them already on our NQICAN website, we published our scoping reports in November. And as I mentioned, these outline what the 5 key quality improvement priorities are for each cancer audit. And the audit teams have been working very hard since then. And after we received our first data for the 6 new audits from January, to start to develop what the quality and the performance indicators and that we will use to measure these 5 quality improvement priority goals. We published our annual report, our progress report, in December. So take a look. We also contributed to the, as you mentioned, the NQICAN, the HQIP cornerstone publication, which is, it's got a great, as you've mentioned, Marina and Vicky, it's got some fantastic resources there, and we were really delighted that Caroline invited us to contribute to this, to talk about NQICAN. So talking about reporting, so each of the audits will report quarterly. So the lung cancer audit is very much taking the lead on this. So they've been reporting metrics for quite a while now, quarterly spreadsheets. These the lung cancer audit have developed the first dashboard, a web-based dashboard using our Shiny which will be launched in tandem with their publication of their next quarterly report next month. So there's lots to learn there that we will apply across the new NQICAN audits. Prostate was next to start reporting quarterly, and because of the data caveats to do with the rapid data, the first 2 reports will be focused on data quality metrics only. So this is the reason for this is because we want to drive up improvements in the completion of key data items within the rapid data set before moving on to reporting metrics in August. For OG and Bowel, because we're moving the CAP system, data collection through the CAP system has ended, and these audits are moving over to using routine data only. So we submitted an amendment to the NQICAN data sharing agreement. So we're hoping to start to receive data for the first time in May, but that's to be confirmed. We're working closely with the DARS team and NDRS on that. So we're hoping to receive data in May, which will enable us for those 2 audits to start reporting data quality metrics for the same reasons, because they're moving to using rapid data in July and October, then following that, metrics from January next year. The 6 new audits, they've been working hard. They've developed their first quarterly data quality reports. So they're being reviewed by HQIP and NHS England at present, and we're due to report those on the 10th of April. And metric publication will start in October. So the audits have also been, the existing audits have moved already to publishing State of the Nation reports, which I'm sure you've seen, or I hope you've seen. So OG and Prostate published their first reports in January this year, Bowel in February this year. The lung cancer audit was first off the block and published the very first State of the Nation report in April 2023, and the next report will be published in April this year. For the 6 new cancer audits in NQICAN, these reports will be published in September this year. So as I mentioned, a key, a lot of activity, a key focus, a key objective for us is to stimulate improvements in cancer services. So there's a lot of work going on within NQICAN where we are moving to developing, designing and implementing quality improvement initiatives for each of the new audits. So it's very timely that we're meeting today. Yesterday, we held our very first quality improvement event. So this was attended by all members of the project team, so clinical leads, our internal team members, members of our NQICAN board, representatives from our patient groups. Caroline and Sarah from HQIP came along. Peter Johnson, NHS England's National Clinical Director for Cancer, was in attendance, as well as members from NHS England National Cancer Programme. So it was a fantastic day, and I just outlined some of the key topics here. So we outlined and discussed, Ajay, our clinical director, talked about what our approach is to supporting and targeting quality improvement. Some of our clinical fellows have been doing a lot of work looking at quality improvement interventions, what's worked, what hasn't worked. We also talked about outcome reporting, and this links very nicely to the previous agenda item about the role of positive outliers in driving quality improvement. And finally, Sudha Sundar, clinical lead from the ovarian cancer audit, and Doug West from the lung cancer audit, talked about their experiences of designing and implementing quality improvement initiatives. We also talked about sort of alignment with other national quality improvement initiatives, for example, from GIRF to Model Hospital, and what the clinical reality of that is. So that's it from me. I'll hand over to Karen, who will take us through the next slides.
Thanks, Julie. Before I do so, can I just check in with Julie? When would you like us to wrap up this presentation? Because I'm just conscious we're at 11:45.
I think when you've gone through your slides, you haven't got many.
Thank
and
you.
Then we should have time for questions. Is that okay with Marina and Vicky?
Absolutely, yeah, thank you.
Thank you. So hi everybody. So as mentioned at the outset, I'm Karen and I project manage the National Bowel and National Esophagogastric Cancer audits at NQICAN. And we'll be spending the next few minutes to talk through the communication channels being used and developed in place across the 10 NQICAN National Cancer audits. This is the first time I've joined this meeting, so it's really great to hear everything that's happening and all these opportunities for collaboration. So that feels really, really positive. I was going to say what you're looking at in screen is the NQICAN website homepage, but actually turns out it's not. So I'm gonna skip on to my next thing that I was going to talk about. Oh, there we go. Perfect. Amazing. And I guess saying for any audit, there's always going to be multiple audiences to engage with and to listen to and disseminate guidance and findings to. So as you can see from the homepage, there's clear signposting to the resources to support NHS professionals and also key resources for patients and the public. Before I talk about the communication channels, I'd really like to share a slide that I saw at the QI event yesterday, which Julie, I think is probably the slide before this one, so the one we were just looking at.
Yeah.
Just very quickly, so these are just two of the results from the National Bowel Cancer Audit, and you'll note from the dates they're pre-COVID. And for me, when I was attending the event yesterday, it just really helped to kind of reinforce that message of, you know, this is why we're here, this is why we're all doing this. So kind of being able to achieve these kind of improvements, albeit a very tiny snapshot and albeit very specific to bowel, I just wanted to take the opportunity to share this particular image. So next slide, please, which I think is the one after the homepage. Sorry, Julie. So starting with resources to support trusts and professionals, and then I'll move on to quickly talk about the comms approach for patients and the public. So it's a multi-channel approach to comms with our very many stakeholders at providers. And so far, and it's developing, this isn't an exhaustive list, is dedicated web resources, newsletters, events, and guidance and FAQs for people to support the audit. Very much see the communication for the NQICAN audits as being a virtuous circle, in as far as the NQICAN audits are very much dependent on those data flows from providers, albeit from routine data sets, but equally providers are relying on NQICAN to help facilitate their QI at a local level. And so it's really important that that collaboration works well. Next slide, please. So first off, dedicated web pages for each of the 10 audits. As you'd expect, there's kind of clear consistencies and approach across the 10 national cancer audits, particularly as they're all sitting now within the NQICAN family, but equally the guidance, the QI resources are very specific to each of the individual audits. And so that's why there's that dedicated resource set up there. Next slide. Regular newsletters, as I mentioned up front. If you're not already signed up to these, please do sign up. For additional updates across all 10 audits, there will be, or there are already posts on X, so formerly Twitter. If this is your kind of thing, it's a really good opportunity to keep up with the latest news on each of the audits. Next slide, please. Thirdly, events. So far this year, there's been the COSD roadshows during January and February, the QI event you've just heard from Julie, and indeed is another plea to kind of sign up for updates, because that's going to be the key way of hearing about these. Also really interesting to hear from Caroline earlier about further opportunities potentially during the Clinical Audit Awareness Week. So that all sounds really positive. Next slide. Mentioned about the FAQs. So with any new audit or significant change to an audit, it's going to generate lots of questions. So a recommendation is to familiarise yourselves with the FAQs which are available. It's not going to answer everything. Thus, NQICAN have in place kind of that dedicated email and phone support for the queries which will inevitably arise. So please do feel free to use it. Also conscious that we're working, again, was mentioned previously, you know, we're all working in environments with finite resource. And so actually sometimes it's, you know, it's just easier to ping an email, pick up the phone if you can't find the answer that you're after, and happy to provide that support. Next slide, please. So this is, so I'm trying to remember why I've put this slide here. So COSD data items, I think this is because where a lot of the inquiries or frequently asked questions can be generated around. So is really to highlight all this information is available on the web pages. But if you do have questions, then do get in touch. It's part of that virtuous circle of kind of ensuring that the data is of that quality and timeliness to support the quality and timeliness of the audit findings. Next slide, please. So moving on to the resources for patients and the public. So I mentioned we have these different audiences. As you would expect with any national audit, there is a patient and public involvement forum who are really key to shaping what we do. So just some examples is ensuring there's a real clarity of message when we're talking to people living with cancer about the audit findings, helping us with disseminating the results. A lot of the people on these forums are from patient charities as well as patients and carers themselves, and are hugely helpful here. And finally, as it says here, shaping improvement priorities. So key remit is not just the audit, it's also about the QI, as we all know, so helping to shape what those improvement priorities should be. Next slide, please. Ah, yes, brilliant. So this is around the very specific to the transition of the OG and bowel cancer audit. So forgive me if this has less relevance to some of you on this call. So there's no new information as such on here, so it's all been communicated before. It's simply to reiterate the message that there's no longer any bespoke data collection for the OG and bowel cancer audits. And prior to the initial data quality reporting, which Julie mentioned slightly earlier, in the interim, if providers are keen to view data completeness metrics, and this is solely for OG and bowel, there is information available via Cancer Stats too, but that will become superseded by the audit quarterly reports, which will become business as usual in due course. Back to you, Julie.
Right, okay, yeah, so this slide just summarises what our next steps are. So I mentioned that the teams are working hard developing healthcare improvement plans. So these will be submitted to HQIP at the end of April and NHS England for review. And further to that, they'll be published on the NQICAN website. I've already mentioned about our PPI forums and quarterly reporting, State of the Nation report. And I just think to finish on saying, you know, there's a much stronger focus on quality improvement for the cancer audits, and using this more rapidly available data will close the audit cycle, I think, for the first time in the cancer audits. So thank you. I'll finish sharing.
Thank you very much. We do have two questions from Di. One is in terms of how many people are in the team for each of the cancer audits. And the other is, how do we know how many cases have been submitted to the NQICAN audits for the purpose of the quality accounts if we're not collecting the data and have to wait for the reports to be published? Di, I don't know if you want to come off mute as well.
Yeah, so those questions, so for an individual audit team comprises 2 or 3 clinical leads, a clinical fellow, a senior methodologist, a methodologist or data scientist, and a project manager. So members of the team work, the audit managers, the methodologists, the data scientists work across more than one audit. So yeah, I didn't count that actually. So it's probably about in total about 7-8 people. And the second question, I think that's a really good question, and we do get these questions coming through about the quality accounts, and I think it would be directing you to for number of patients diagnosed in a period of time, it would be that information should be available through the cancer registry. So NGRS have they have regional data improvement, data liaison leads. So all of the contacts are in an FAQ on the NACAN website. So I can pop that in the chat in a moment, actually. So that I would suggest that's your point of contact for finding out, and also your point of contact for finding out about data completeness for the COSD data items that are submitted by your trust.
Perfect, thank you.
Thank you. Do we have any other questions for Julie at this point?
I'm not seeing any.
No, you're all right, Julie. I think you've obviously answered everybody's already.
That was brilliant. That update was absolutely fantastic. I think it clearly shows us that we're going to get our hands on that more timely data, and the big focus on QI will be amazing, I think, for our local teams, and seeing that focus from the people that are positive outliers as well, that we know are doing it really well, because that's what we want to know in our organisation. Well, what are they doing differently, so we can try to change our pathways so that we're improving as well. So that's brilliant. Thank you for sharing all that information. And actually, it'll be great to have something else again in Clinical Audit Awareness Week, as yourself and Caroline has suggested. That would be brilliant.
Yeah, that'd be great.
Lovely.
And then just one more point. I know we're running out of time, but in the quality event we had yesterday, one of our clinical leads made a really good point that that himself as clinical lead, they'd been he'd got an urgent message from his medical director to say, you have to come and see me. We've been identified as an outlier. And then when he actually said, well, we're not a negative outlier, we're a positive outlier, the message changed, and he was told, well, you don't need to come and see me anymore. So this clinical lead yesterday was saying, well, I do want to come and see you, So yeah.
It needs celebrating, doesn't it? It needs recognising and celebrating and sharing widely. And your patients need to know as well, don't they?
Yeah.
Yeah, really important. See, actually, that's a valid point, isn't it?
Yeah.
where we're doing well.
You've got our contact and I'll pop that in the chat as well for NatCan. So if you've got any further questions after the meeting today, please get in contact.
Yeah, that's lovely. That's brilliant. Thank you so much. So I'm aware we've got about 3 minutes. Were there any other questions, Verena, or shall we summarise?
I haven't seen any further final questions from anybody that haven't been answered as we've gone along. But obviously, if anybody does think of anything afterwards, please do feel free to email us, and we could add it onto our Q&A list from the meeting.
That's brilliant. So I think we've got a lot there actually to take out from today to see what we can do to support our members a little bit further, really, to strengthen things. So thank you for contributing. Thank you for raising all your questions. We will populate that Q&A, and as we're going through and double checking that chat, anything that we haven't got a response for, we will go and get a response for, and we'll get that published as well. And for anybody that's on the call, please do be feeding back to your regional network at their next network meeting if their chair hasn't been present this morning. Obviously you're here as a member of your regional network as well, so please do take these discussions back into that regional network. I'm sure they will crop up again as we have the June open meeting and as we move into Clinical Audit Awareness Week. Don't forget, we've got the forum, we've got the NHS Futures platform as well. We can get discussions going there on the forum for the local, the Futures platform for around the national clinical audit. So let's get on there. I know there's been an issue raised with the platform in the chat, so I'll try and look at that urgently today, and we'll see if we can escalate that to Futures if we can't resolve it. But thank you so much for joining us. Yeah, thank you so much for contributing. Thank you for our key speakers as well. It's been a fantastic meeting. it's been recorded. We'll make sure that we get the links out to you all so that you can share that widely with your teams as well for anybody that wants to listen that hasn't dialed in, and the slide packs as well. And we've obviously popped the NQICAN inbox email address into the chat as well if you've got any other further questions, especially where you perhaps might have more lengthy narrative that you want to put forward to us. So it's been lovely to see you all, and yeah, we'll look forward to seeing you all soon. So thank you very much.
Thanks, Vicky.
Thank you.
Take care, everyone. Thank you.
Bye.
Thank you.